Good afternoon, everyone, and welcome to this webinar. My name is Federica Margheri. I am the Executive Director at the European Health Management Association, and I'm delighted to have you today for this webinar titled From Medication Waste to Smarter Medication Management, Practical Pathways for EU Action. We're very pleased during this event to present a paper that we have published a couple of weeks ago on a problem that is both structural and urgent. Because medication waste is a triple burden of clinical harm, economic inefficiency, and environmental pollution. And this paper really wants to move from evidence to implementation, which is something that we do routinely at the European Health Management Organization. And we want to examine today what works, what it costs, and what the EU can really do to accelerate the change. We have an excellent speaker with us today to talk about this topic. I'm very thankful for you to be here. Thank you so much for making the time. Before going into hearing from them, I would like to acknowledge the support of BD that has made the publication of these paper possible and is supporting these webinar as well. I would also like to give you some, let's say, rules of engagement, if so we want to call them. Please do use the chat to ask any questions you may have to the speakers. If we do have time, we will be happy to respond to those at the end. Otherwise, the speaker will probably use the chat to address your doubts and questions. This webinar is being recorded, so you will have the opportunity to access the recording afterwards and, of course, re-listen to the presentations. The recordings will be available on our website, which is ehma.org. And without further ado, I would like to introduce our first speaker, my colleague, Dr. Sergio Oliveira Formoso. He is a policy officer at the European Health Management Association, and he will be introducing the paper of which he is the main author. Sergio, over to you.
Hello, Federica, and thank you. Thank you very much for this warm welcome. Let me share my screen so that we get in it together. And there we are. It's a little bit slow, the program today, but here it is. Sorry. So as I was saying, thank you very much, Federica. My name is Sergio Oliveira Formoso. I'm a policy officer here at the EHMA Secretariat. And today, let's gonna kickstart this webinar, which is very interesting. And I think it's very timely at this point because of the problem of medication waste intersects between different areas in health, in environment, and in economics. So in general, and just to begin, let's gonna put this problem in context across Europe, because this is something that we can see all over the places and all over the member states. We don't have really big data on in terms around the economy, the European Union, but we do have data that can illustrate this according to different member states. So, for example, in Greece is reporting around 1 billion euros of unused medicine annually. France, in 2018, it reported more than 17,600 tons of unused medicines or expired ones. Belgium here itself is reporting more than 700 tons of them, and Spain it's recovering around more than 100 grams per capita of medication waste back in 2022. So this is a big problem, and we have the opportunity to try to solve this. Medication waste is a signal for systemic failures, and it is driven by certain important stuff. This between the main drivers is non-adherence, which is the fact that people do not adhere properly on the medications that the doctor has been prescribed to them. Inappropriate prescribing, because everyone can make a mistake, and this will be solved, but then the medication will be wasted. Inadequate training in patient education, that's a major deal. And then failures into the treatment adaptation, because once, for example, you have a prescription for one medication, then if you need to treat it to adapt it, then you can lose these medicines in the whole process. This has effect because it may be that there are no benefits from the therapeutic part of this treatment. This can have also negative effects on the patient outcomes, and it can worsen the condition of the patient, and it can increase the risk of avoidable harm. The risk of avoidable harms is increased, but it also have an economic impact and is huge. We are reporting between 80 and 125 billion euros annually losses in Europe just from this. And this is just considering preventable hospital admissions, emergency care utilization, and disease progression and premature mortality. So another thing that we are mostly not taking into consideration in a big part is the environmental impact of this medication waste. We now know that from recent study has shown that pharmaceutical residues are actively present in European soils, waters, rivers, and they have described more than 150 active pharmaceutical ingredients detected in this environment. Between them, we have hormones, we have antidepressants, and we also have antibiotics. And this is a big problem for AMR, for example. But all of this is not affecting everyone in the same point in the same place. So downstream communities near pharmaceutical manufacturing sites are more affected by this. Hospital effluent discharges points or areas with weak wastewater infrastructure are really at risk. And while these active pharmaceutical molecules are in very low concentration in water and soils, we still do not understand the long-term effect of them and how they can really interact with the human body, especially for children. So this is a problem for the future. And here's the paradox. We are talking about medication waste, but in Europe, we are recently talking a lot about medication shortages, sorry. And the paradox is that medication waste is coexisting with critical medicine shortages across Europe that are putting our health systems at risk and the patients at risk. While the EU is responding somehow to this problem through the Critical Medicine Act and through the revision of the pharmaceutical package. There is still a gap, and the gap is that there is still a gap because we are not addressing directly the problem of medication waste. So we are missing our opportunity here. We are missing the opportunity to enhance supply resilience, reduce environmental impact, and improve patient health outcomes while saving money and putting Europe in a more competitive place compared to the rest. So, medication waste, it's drive by systemic drivers, and there's so many of them, but I just want to touch on the most important things. They can be divided in behavioral, clinical, and structural and organizational, and the most important one, according on the behavioral category, would be medication non-adherence, because as we explained before, if the patients do not adhere to medication, then they will not have the benefits of that medication, and then they will go again to the doctor and they will spend more money. Clinically speaking, polypharmacy and clinical complexity, most likely, this is most important for older patients, older adults, or people which is having a very complicated treatment changes, inadequate medication reviews, all of this and patient mortality, all of this will have an impact on medication waste. For example, if a patient dies, then there is some medication that is wasted there because it cannot be used again. Medication, if medication reviews are not done, same story. And then there is a structural and organizational drivers. For example, the pack size and the dispensing policy mismatches, the weak disposal infrastructure, and limited medication redistribution system. These are very complex. These are very complex drivers to describe here in this webinar, but I am so sure that my colleagues are going to talk a bit more about pack sizes and different technologies that can be used to that after my intervention. So how do we address medication waste through evidence-based approaches? Well, we have discovered through our research that we have six main um, actions to make. We can change and be a little bit more active on the reimbursement models that our healthcare systems are using at the moment. Second, we can improve health literacy for patients because this is what they are, this is part of their responsibility, and this is going to make them ascribe to their medication even faster. We can improve our e-prescribing technologies, and this is something that the European Union is not forcing, but is encouraging to do through the European Health Data Space. And then we can enforce medication reviews for them to happen every 6 months, for example, or every year. We can include those dispensing technologies that my colleagues are going to walk through them in a bit. And then we can adapt these digital tools that we are seeing right now so that they can help the different areas that we have been describing, I have been describing just right now, to advance further and advance quicker. So our policy recommendations, and you can see and you can read about them more in our position paper that you can find in our webpage, and I'm surely it will appear somehow soon in the chat. But so the first one is we need better surveillance integration. We need EU-wide medication waste monitoring and policy integration, because if this is not if only one member state moves, the problem still remains the same. Second, medication optimization. We need to optimize this medication use and strengthen professional capacity. For this, we also need innovation. We need to promote innovative digital and health technologies. We need to get industry to work with us and to get responsible to address these pack size mismatches and to improve the bulk availability of the different medicines. And we need to increase and improve the collaboration. We need a EU multi-stakeholder platforms to be created. We need to improve our coordinated actions. So in general, and although this is the sixth one that we are showing here, what we want is to leverage all the pieces that we have in the EU legislation to be able to address effectively on medication waste. And I would like to finish with a quote that I like. I think it's nice, and it will sum up a little bit my intervention, is that the evidence is clear, research is there. The priority now is implementation, and we need to advance in medication management. This means moving from fragmented efforts to integrated solutions that deliver efficiency, safety, and sustainability at scale. Thank you very much, and I'll stop sharing now and I give the floor back to you, Federica.
Thank you. Thank you. Thank you very much, Sergio, for this a very clear presentation of the paper that we have developed as EHMA. And now I would like to invite a representative of a country that has done particular progress with regards to implementation and the reduction of medication waste. So I'm very pleased to have with us Mr. Lars Vogelsang. Hopefully, I've gone close enough again to not mispronouncing your last name. He is the head pharmacist at the Spitz Group, and he will walk us through how automated dose dispensing is working in practice and what the Netherlands has done in terms of implementation. Lars, over to you.
Thanks, Federica. Yeah, across Europe, healthcare systems are under real pressure, meaning aging populations, polypharmacy, staff shortages, and above all that, a growing concern about medication waste. In the Netherlands, automated dose dispensing has grown into a major pharmaceutical care model that addresses all these challenges at the same time. So I want to walk you through it, why it works, how it's organized, and what I think Europe can take from it. But first, briefly about myself. So I am the managing pharmacist at Spitz Oosterwolde, an automated dose dispensing facility in the northern of Netherlands. In my daily work, I hold final responsibility for the care that is provided by our end product, so the medication rolls. I am also a member of the Dutch working group, currently revising the Dutch EDD guideline, because I firmly believe that every patient receives, deserves a safe care. To give a concrete example of how the system works in a daily practice, let me introduce you to Spitz. So we have 25 years of experience as a centralized EDD pharmacy. We are responsible for around 67,000 patients and their daily medication in medication rolls. And we deliver medication rolls to around 200 customers in the north and mid of Netherlands. Spitz exists for two main reasons. First of all, the clinical benefits of the medication roll itself, meaning improved medication adherence, reducing medication errors, and improved medication safety, specifically for patients with polypharmacy. And second, logistical advantages of centralized dispensing to concentrate production, validation, automatization into one specialized pharmacy. We can guarantee quality and scalability while the local pharmacy can focus on direct patient care. In this way, Spitz complements rather than replaces the role of the local pharmacy. And this system also allows the local pharmacy to deliver a high quality automated dose dispensing service to their patients, regardless of size or location. At the heart of automated dose dispensing lies the medication roll itself. So, the medication roll consists of medication bags, sachets, which contain the full oral medication intake for 1 moment in a day, sealed, barcoded, traceable, and if opened, ready to swallow. So really simple thing. The medication roll delivers several things. So I have here 4 things that it can deliver. So first of all, medication adherence. The core value of the medication roll is that it translates complex medicine regimes into clear, structured intake moments. This greatly reduces confusion and administration errors, particularly in patients with polypharmacy, cognitive decline, or with reduced self-management capacity. So by simplifying medication intake, the role supports medicine adherence and the correct use of medicines. This is not only important for clinical outcomes, but also to avoid harm and eventually costs. In addition, the medication arrive prepared, checked, and labeled, and for each individual patient, this greatly reduces administration errors at the bedside. Third, so every nurse knows the feeling: too much to do, too little time to do it. The medication roll can remove one burden off their shoulders. So no more sorting, no more preparing doses for individual patients. The medication arrives ready, clear, checked and labeled, and for each individual patient, so they can directly administer the medication. And in addition to these 3, the medication roll enables short dispensing cycles, typically 1 to 2 weeks, This means therapy change can be implemented quickly and safely, resulting in far less waste when therapy is adjusted or stopped. Beyond reducing waste in care settings, the centralized production model is also a more sustainable approach. So as mentioned, the medication roll enables short dispensing cycles, so resulting in far less medication that ends up unused or discarded. Also, at Spitz, we can control the packaging waste stream, and that is not spread across thousands of households in the Netherlands. Third, in this system, the patients only hold the next cycle at home, so very little medication they have at home, and it prevents from medication to pile up and eventually end up in household bins or even in the sewage system. Last of it, because the patient don't have these large stockpiles at home, the risk of medication is reused or shared or passed on even to family members is structurally reduced and avoid eventually harm and cost. This slide shows a schematic overview of how a patient receives medication roll. It's important to emphasize that this is particularly for patients that are have polypharmacy or have difficulties to managing their own medicines. So you see what this picture shows, and this is important. A local pharmacy is the EDD pharmacy's customer, and we as an EDD pharmacy actually know a little about the patient. So basic patient characteristics, and we know which patient uses which oral medication in the EDD, also in the medication role. We as an EDD pharmacy operate as a specialized production partner, and we produce the medication rolls under validated conditions and return it to the local pharmacy, where they distribute the medication roll to the patient at home or even to patients in a care institution. It's important to know the local pharmacy always stays the patient trusted point of contact, and we as an EDD pharmacy work behind the scenes so they can deliver better care up front. All of this only works because we have it rests on a regulated professional standard. It has quality structure that is GMP compliant, meaning we have processes are defined, responsibilities are explicit, the quality control is risk-based, and this standard is supervised and enforced by the National Healthcare Inspectorate, and it's meaning that it's actively maintained in daily practice. So it's an important and quite deliberate thing of a element of this Dutch standard is that it allows production for other patient tests from other pharmacies, and that single legal provision is enabling is what made specialized EDD pharmacy possible, while clinical responsibility stays with the local pharmacy. So on the centralized side, we produce the medication roll on the validated conditions, and on the decentralized side, we have the local pharmacists that do medication reviews and therapy adjustments. And this combination of centralized production with decentralized clinical responsibility, that's the Dutch combination of the EDD pharmacy. Within the EDD pharmacy process, we are permitted to switch between therapeutically equivalent products, meaning products with the same active pharmaceutical ingredients, same dosage, and same pharmaceutical form. And it allows the therapy to go ongoing uninterrupted, while the EDD pharmacy can have a focused assortment, and this eventually prevents expiry rates and reduces the logistical complexity within the EDD pharmacy. None of this is sustainable without a reimbursement model. In the Netherlands, the local pharmacy receives a fixed fee per medication roll, and the medication is reimbursed separately. And this is important. The medication of the medicines in the roll are excluded from the preference policy. So sorry. And this model supports thereby centralized production, reward short dispensing cycles, and structurally reduce waste. And in this way, reimbursement is ultimately the lever that determines whether all of this works in practice, in my opinion. So if I may share, what Europe can learn from it. So automated dose dispensing is a structural solution for medication waste. Centralization of production captures waste that local dispensing simply cannot. And reimbursement, decides whether all of this actually happens. Thank you for your attention.
Thank you. Thank you so much, Lars. So that was an extremely interesting and informative presentation. Shifting from the Dutch model, I would like to pass on to Dr. Daniele Bellavia to understand a little bit more the economic side of things and examining the economic case for digital and automated medication management. So Dr. Bellavia is a research associate at LUIC University in Italy. Daniele, over to you for your presentation.
Okay. Turn off the camera, but the important is that the slides are shared. Well, thank you for the warm introduction. Today I'm here to show you the main results of the study that me, together with my team, published recently. And it is about the economic and financial impact of automated and digital technologies in the medication management inside European hospital. A lot of stuff to say, very short time, but let's try to go through it. A little bit of context. Sorry, I put in presentation mode. Okay. A little bit of context. Literature says that in European hospital, up to 0.1% of all doses are affected by medication error. And this, of course, leads to a chain of inefficiencies that lead, of course, to higher cost. And of course, since the theme, the topic today is medication wastage, of course, there is also that aspect, and we will see through very soon. Also, literature says that automation and digitalization could reduce these errors and inefficiencies by 50%. Unfortunately, right now, the adoption and implementation of these technologies across Europe is not wide, is still limited. And of course, there are some nations that are a little bit far in advance, some other that are a little bit behind, but still there is a lot of diffidence because, of course, there are high upfront costs, so costs of investment that are important, and there is right now the lack of robust and large-scale economic evidences demonstrating the return on investment. So starting from these premises, we wanted to, of course, to start this study where we wanted to give robust economic and organizational information to the decision makers at the hospital level across Europe, across the 27 nations of the European countries plus the UK. And with a long term, so 10 years of analysis, of projection of the results, assessing this economic and financial impact on 5 key technologies. And some of them were already cited by Lars. And let's see very quickly. The technologies under studies, under assessment, were the inventory robot in the central pharmacy, the unit dose system, the automated dispensing cabinet to be installed inside the wards in a hospital, smart infusion pumps with dose error reduction system, and finally, the medication traceability platform in the setting of oncology. And this could be quite interesting in the topic of wastage, because of course, wastages in oncology could be very expensive. Very quickly, some methodology. We, starting from the modelization, from assuming the hypothesis of assessing the economic impact in a standardized hospital of 561 bed, that is the representative average of the standard European hospital. And of course, the initial investment and the operational savings were estimated using country-specific data because, of course, the salary, for example, of a nurse in Italy is not the same of the salary of a nurse in the Netherlands, for example. And we also wanted to do a little bit more, and we scaled also this result proportioning the economic impact in a hospital at a national level, making the proportion about using the number of beds inside every country. And of course, finally, we made the sensitivity analysis since a lot of modelistic assumptions were done. Very quickly, we of course related a lot on the literature. So we made an extensive literature research and review. And in particular, we wanted to translate with an economic value 4 main organizational and clinical benefits. And they are, of course, the reduction of medication wastages, the reduction of the unused stock, for example, for what Sergio was saying at the beginning of the unused drugs in hospitals, the reduction of medication errors that could lead to a prolonged length of stay for the patients, and finally, the releasing of time of pharmacists, nurses, and in general healthcare personnel that right now is devoted just to, let me use this term, logistic tasks, while they could actually their time could be used in tasks. The main result of this analysis was the production of 3 financial indexes. They are the returns, of course, the net present value. €1 today does not have the same value of €1 in 10 years. And finally, and probably most important, because it's the financial indicator that is easier to read, is the payback time. So the time needed, the number of years needed to recover from the initial investment, thanks to the operational and economic savings. So let's go straight to the main results. First, the first chart on the left is pretty interesting because it represents at hospital level, so in the average European hospital, what could be the initial investment for the full implementation of those 5 technologies and the potential annual saving. And we're talking about potential annual saving because of course, we considered also in the 10 years horizon, we consider the learning curves. So the investment is quite relevant, but personal opinion, not so relevant in the economy of an average hospital in Europe. But this is, again, my personal opinion. And very interesting is the relative height of the annual saving, the potential annual saving, because we can see just by at a glance that the green columns are pretty high and pretty close to the top of the red column. And in particular, we performed the analysis of the calculation of the payback time. And we found that each of these technologies have a payback time that is between 2 and 4 years. So it is possible by this analysis to recover from the investment in a medium short time. And this is, in my opinion, one of the most valuable information that a decision maker could have in this setting. Just one disclaimer. Of course, we are presenting right now, because of the lack of time, just the average European hospital results. But of course, in our analysis, we stratified for each one of the 28 nations that we included. About the return on investment and the net present value, they are very positive. In particular, 2/3 of the technologies that are most representative of for the process of fully integrated automation inside a hospital have a return on investment above the 200% in 10 years, let's remember. And the net present value is pretty superimposable to the results of the return on investment. Not exactly the same, but still superimposable. What is, in my opinion, really important to say today is that we wanted also to give a breakdown of the savings, but right now is at European level, so continental level, 28 nations in 10 years. And we can see that in particular, the wastage reduction savings is something like, in 10 years, 574 million euros, which is pretty much. And it represents almost one of the main voice of saving, since it is almost the 32% of the possible achievable saving, thanks to the implementation of automation and digital technologies. Just few final numbers just to give the super average and aggregate results. At hospital level, we have a net present value of almost 3 million euros in 10 years. And at the European level, we have a net present value of almost 10 billion euros. The average return on investment is above the 200%, and the payback time, again, is between 2 and 4 years. So interesting value. Very quickly, of course, this study, this model has many assumptions, many modelistic assumptions. And since this factor, we also performed a sensitivity analysis on two main factors that could strongly modify the results, but still the sensitivity analysis proved that these results that we obtained are pretty strong. And if I can say also, just by confronting to other professionals, maybe pharmacists and so on across Europe, it was a surprise from my side that those results were actually superimposable to the reality of some business cases. So very quickly, just few key messages. The financial performance are good, and this study proves the economic viability of digital and automated technologies. Of course, this is just the translation, the economic translation of very important organizational and clinical benefits. And of course, we can use automation and digitalization as a strategic leverage for the future of healthcare in Europe to address the reduction of wastages and the general change of our healthcare systems. And thank you very much.
Thank you very much, Daniele. Really appreciate the great value of the information and how we have asked you to condense it in 10 minutes. So thank you for doing your best with the limitation of the time that we gave you. Please do feel free if there is a publication or if you want to share a link in the chat so that our participants can discover more and maybe read all the data and the great research that you have done. And now I would like to introduce a recorded message from Professor Ranieri Guerra. He is the Vice President of FEAM, the Federation of European Academies of Medicine. Professor Guerra is currently outside of Europe and with some very limited internet connection, and therefore wanting to be here has recorded a video that now my colleague will share.
Working.
Apologies for this. Good day and thank you. I'm talking to you from Basra, Iraq, where I am on a challenging mission. That's why I'm not with you directly. My apologies for this. The figure on this slide, 80 to 125 billion euros every year, is what medication non-adherence costs the European Union. Per citizen, that is 210 to 360 euros a year, 5 to 10 times what the member state spends on its annual flu vaccination program per person. 200,000 premature deaths sit on the same balance sheet. In the next 12 minutes, I want to make one argument. Medication waste is not a recycling problem. It is a recurring, measurable tax on European healthcare, paid every year in money, in lives, in environmental load, and the evidence is now strong enough that we can put a price on continuing to ignore it. Here's the route. First, a 3-layer cost taxonomy, so the headline number behaves like a budget line rather than a slogan. Then a per citizen indicator, then one worked example on anticoagulants, then the ROI bands behind every EHMA recommendation, then the cumulative price of inaction across 2026 to 2030. I will close with 3 asks. Let me start with the taxonomy. When we tell finance ministries that medication waste costs Europe up to 125 billion euros, the number is so large, it sounds rhetorical. It's not. It bundles 3 very different layers, and once you separate them, the conversation becomes much easier. Layer 1, the direct costs. The acquisition value of medicines that are dispensed but never therapeutically used. Return to the pharmacy, expired in the cabinet, discarded at home. Greece reports around 1 billion euros of unused medicines a year. The English National Health Service roughly 350 million, about 4% of its primary care medicines budget. French households discarded 17,600 tons in 2018. Belgian pharmacies recovered more than 700 tons in 2024. These are the part of the iceberg above the waterline. Layer 2, operational. The handling that waste creates around the dispensing chain. Reverse logistics, hazardous waste disposal, pharmacist time, IT and audit overhead, and very specifically, manual deblistering. In Germany, France, Spain, and Italy, national medicines law restricts pharmacy repackaging, which means hospital and community pharmacists who want to use automated dose dispensing spend hours each week popping tablets out of blisters by hand. Producer responsibility schemes sit in this layer too. Conservatively, operational costs add 10 to 25% on top of the direct waste figure. Layer 3 is where the real money lives. The consequential layer, the downstream clinical, social, environmental costs caused by the same systemic failures that produce the waste. Non-adherence above all. The 80 to 125 billion euro figure sits here. So do the 200,000 premature deaths, the 30% of 30-day readmissions linked to no adherence, and the 150 active pharmaceutical ingredients now detected in European water bodies. The point is this: most published estimates only see the first layer, the smallest of the 3. Any policy that touches non-adherence is in fact a layer 3 lever, even when it is sold as a layer 1 intervention. That distinction matters when you are negotiating a budget line. Stack the 3 layers together, divide by the European Union's 447 million inhabitants, and you arrive at a defensible per capita indicator. 20 to 50 euros per citizen per year for direct costs, 10 to 25 for operational, between 179 and 280 for consequential. Add them, and the composite figure is 210 to 360 euros per European per year, roughly 5 to 10 times the per capita cost of an annual flu vaccination program. Recommendation 1 of the EHMA position paper calls for European-wide medication waste surveillance by 2030. A per capita indicator like this is the simplest way to operationalize it and the only way to compare member states meaningfully. Within Europe, the Netherlands shows what is possible. Dose-based reimbursement, near universal automated dose dispensing, the G-standard database, and the LSP exchange point. By every measurable indicator, they are below the European average. At the other end, the 4 largest national markets, Germany, France, Spain, and Italy, show how regulation alone can stall progress. Now, let me put a price on one specific structural driver, pack size mismatch. I will use direct anticoagulants, the ACs, the apixabans, and the rivaroxabans. as the worked example. I picked them deliberately. High unit cost, large patient population, frequent treatment changes, and rigid 30-day pack architectures. The cleanest way to make the economic case to a member state pharmacist or a finance ministry without complicated modeling assumptions. Roughly 6 million European adults are on a DOAC at any given time, and apixaban accounts for about half. The standard apixaban pack contains 60 tablets, a 30-day supply at 5 milligrams twice daily. Real-world cohorts put the 12-month discontinuation or switching rate at around 25%. When a patient switches MedIWASTE, and most do, the average residual is about 13 tablets, roughly half a pack. Ex-factory cost across member states hovers around €1.30 per tablet. Now do the arithmetic out loud. 3 million apixaban patients, 25% discontinuation, 13 residual tablets, €1.30 per tablet, 12.7 million euros a year of direct waste for apixaban alone. Scale to the full DOAC class and you reach 25 to 40 million a year. Add 15% for operational handling and you cross 30 to 45. None of this counts the bleeding events or avoidable hospital days, yet under dose-based reimbursement, the model in the Netherlands, Sweden, Norway, Finland, and Denmark, 60 to 80% of this waste is recovered. That is what implementation studies show. Statins make the same point at higher volume and lower unit price. Atorvastatin alone adds another 18 to 25 million euros a year. Combine the two classes and pack size mismatch is already 100 million euro line item. Hidden in this arithmetic is the policy unlock. Recommendation 4 of the EHMA paper, manufacturer bulk supply, automation, ready formats. Without it, every downstream lever carries a hidden duplicity tax. With it, those levers compound. Member state finance ministries respond to ratios more than to absolute numbers. So here are simple defensible ROI bets for each EHMA recommendation. The lower bound is drawn from peer-reviewed valuations in market-based health systems. The upper bound reflects mature implementations, mainly the Netherlands and the Nordics, as said. Automated dose dispensing combined with dose-based reimbursement returns 2 to 5 euros for every euro invested. Structured medication review, 2 to 4. Deprescribing programs, the highest performance, 3 to 7, because they cut drug spend and consequential cost at the same time. Patient education and health literacy interventions, 2 to 4. Smart packaging and digital adherence, 1.5 to 4. E-prescribing and cross-care interoperability, 1.5 to 3. Producer extended responsibility is at least break-even, more when bundled with redistribution. 2 observations. First, every single lower bound is above 1 to 1. There is no recommendation in the EHMA stock that fails to pay for itself, even on the most cautious interpretation. Second, the levers compound. Pack architecture enables AD. AD enables dose-based reimbursement. Reimbursement creates the economic case for medication review. Review feeds the prescribing. Mature ecosystems recover more than the sum of the parts. And here we come to the critical figure. If we do not do anything, if no member state adopts dose-based reimbursement, if pack architecture does not change, if regulatory restrictions on repackaging stay where they are, the arithmetic for 2026 to 2030 is unforgiving. 80 to 125 billion euros a year, multiplied by 5 years, gives a cumulative range of 400 to 625 billion euros. 200,000 premature deaths a year, multiplied by 5, gives roughly 1 million premature deaths across the period. And that is before we count the continued release of pharmaceutical residues into European water bodies. More than 150 active ingredients already detected, and the contribution of avoidable antibiotic waste to antimicrobial resistance. 400 to 625 billion euros is hard to picture. It is comparable to building and equipping 30 to 50 large university hospitals. It exceeds combined budget of the European Union Life Program and Horizon Europe's health pillar over the same period. Whatever frame you prefer, the conclusion is the same. Inaction is not a neutral default. It is the most expensive policy option on the 2026 to 2030 table, and the only one we are currently on track to choose by accident. Let me close with the three asks. First, adopt the per capita medication waste indicator across member states. What gets measured, as we know, gets managed. The EHMA paper's 2030 surveillance recommendation needs a single comparable number, 210 to 360 euros per citizen per year, and we have one ready to use. Second, embed dose-based reimbursement and bulk supply requirements in the Critical Medicines Act amendments. These are the unlocks for ROI on every other level. Without them, automation and add carry hidden the blistering tax. The Article 30(2) amendments are drafted and ready. Third, reframe inaction. 400 to 625 billion euros and 1 million lives across 2026 to 2030 are not abstract. They are a budget envelope being burned every 5 years. Medication waste reduction is not a cost containment exercise. It is a clinical, environmental, and economic triple win, and one of the rare policy opportunities in European healthcare where every objective points in the same direction. Thank you very much.
Well, we all do, Professor. I think, okay, perfect. Now I don't hear myself anymore. So I would like also to thank Professor Guerra for having recorded this video as he could not be here present with us. And now I would like to invite on stage, if so we can say, our last speaker, Dr. Elena Petelos. She is the president of the Global Health section of the European Public Health Association, EUFA. She's also a senior research fellow in public health at both the University of Crete and the University of Maastricht. Elena, thank you so much for being with us. I would like to ask you a little bit of a more political or policy question, if I may, especially because in the last part of the intervention of Professor Guerra, he mentioned some of the European funding instruments. So in this period, the negotiation for the new multi-annual financial frameworks are underway. They're starting, and so in your view, what is the case for treating smarter medication management as a strategic EU investment priority? And what does credible European support look like?
First of all, thank you for the invitation, and thank you very much for generating this paper, or position, if you like. Some of the topics that are tackled we have been discussing for a very long time, from dispensing to having an indicator which is appropriate for smarter medication. I think the first big FP6, FP7 thing we did on overprescribing and overconsumption of medicines, including, since Greece was mentioned, leading to waste, dates, it's now almost 15 or 16, maybe 18 years back. So first of all, to make a comment that the paper, the positioning is very sound, is evidence-informed, and tackles a very important aspects which may not be explicitly mentioned in the provisional MFF form. But if you consider the aspects of resilience, of patient safety in relation to health system sustainability and reducing fragmentation, cross-border care, the preparedness, and of course, critically, the interoperability aspects, including because of the emergence of EHTS and the need to tackle waste and reward innovation, then it's perfectly aligned. Before putting some concrete, what could be concretely considered as support or actioning, just also to say that there are a couple of aspects which perhaps are not mentioned in the paper explicitly, but definitely they bridge to the paper. And I hope to see more work on this expanding, because of course, as you said, this is the beginning of a dialogue that has to be expanded and enriched and hopefully actioned upon. And these are pharmacovigilance, one of the best regulated aspects that we have within the European setting, particularly because it's not what traditionally just was. It's something much more complex. We have an aging population, we have polypharmacy, we have NCDs, we have a very serious issues of multimorbidity and over-medicalization of care. We have poor adherence and of course, very fragmented care pathways. And fortunately or unfortunately, our populations, European populations, live in islands, live in mountains. So we have an idea. Greece was mentioned at 1 billion waste, but who knows what the actual real numbers are? And of course, the harm is not quantified there. And then, of course, HTA, even the Biotech Act, brings another pillar. Absolutely, we have been discussing those aspects in relation to reimbursement, but you need to have monitoring mechanisms for that. And you need to consider how you will be implementing them. To go back to the essence of your question in support, verbiage is a start. The right words are a start. So, of course, if you want to tackle these aspects and also meet your strategic agenda and priorities, particularly because we have EU for Health, EHTS coming out with guidance, Digital Europe agenda, which is massive, you need to see optimization in terms of the partnerships, both at European and national regional partnerships under the MFF, because the partnerships form the basis for funding research, for implementation research, which was Professor Guia briefly mentioned, but there's very little of and even very limited funding. And of course, workforce capacity, because traditionally clinical trials, hospital care provision, public health have been fragmented. And the people need to be familiar with new systems and new modalities. And then critically, for interoperability standards, there is emerging work that could be used and outcome frameworks, but we don't speak, the member states cannot scale up and compare solutions at the moment. We are very fragmented. We have some efforts, but they're not strategically supported so far.
Yeah.
And of course, not just for health, cross-sectorally, yeah, because it's cross-sectoral aspects.
Thank you, Elena. And clearly today we have heard a lot of operational, economic argument, all very strong. So there is, of course, a wealth of knowledge, but also of arguments to be made. But this doesn't necessarily translate into routine practices. There is always sometimes a gap in terms of implementation. So from your point of view, what role can these evidence, digital health, AI play in accelerating the adoption of smarter medication management approaches?
Yeah, we already have emerging evidence on this. We know we lack a robust infrastructure. The same infrastructure that would serve implementation of such solutions would also serve many other aspects for real-world evidence generation, quality data, if you like. And of course, it would allow us to evaluate real outcomes and inform benefit risk, dose adjustments, clinical guidelines, and so on. Also empowering a little bit more healthcare professionals at different levels of care. There is an aspect which we have been discussing progressively more and more. It's one example in terms of accelerating the adoption. Better evidence in terms of the current problem state. I mean, we have some numbers, but as I said, we don't have a comprehensive overview of mapping the particular aspects that are affecting in each member state, in each region, this issue. And we don't necessarily have the right system indicators to monitor how small interventions to improve will actually lead to improved outcomes, to more safe care and so on. So I think particularly for the populations which could be underserved or underrepresented, and there are big projects on that already, it's very important to know that we can have a different type of infrastructure, which would also serve other European priorities, in parallel systems. So I think if you couple the strategic agenda to the points about these things paying for themselves for innovation reward, then you have absolutely no dissonance to current priorities. And then critical aspects for this, digital tools facilitate data collection to some extent, but you need to have some care. And AI, we already know, can support safer prescribing, early identification of medication-related risks, and better continuity of care. But again, if we want to tackle polypharmacy, poor adherence, and so on, we need to be very, very careful. We've seen good practices, dispensing is one, that allow to study what needs to change, not only just carry over best practice, but look at the legislation, organizational level of care, and whether not just funding the pilot, but whether scaling up can be sustained after the pilot and it can become a reality, not just in policy, but in practice.
Thank you, Elena. I do have one last question for you, and then one last question for everyone in the panel. So please prepare yourselves. So one of the things that happens with the digitalization and digital health is that, of course, it can widen inequalities. So how can we ensure that smarter medication management solutions do not widen inequalities and actually improve equity, accessibility, positive outcomes, especially for vulnerable population, older adults, as we have an aging population?
I'll be very brief because we are on the hour, almost past the hour, that we don't have a widely accepted equity frameworks for either aspect, for trials or for equity or for HTA. And even we already know that medication-related harms disproportionately affect the elderly and the multimorbid and the socially vulnerable. We know that. So the digital systems could be used, and I mentioned one example of pharmacovigilance, but also you can monitor disparities in adherence. And of course, we have advents in the electronic health records, in the labels, and expanded share, big projects that are coming together, make the infrastructure sustainable. So move a little bit further from just doing, let's say, isolated efforts, because then we somehow lose very good, high quality projects. And I can mention many analyses, as I said, that we had 10, 15 years ago that were already flagging these issues. One last thing, one sentence. We didn't perhaps discuss enough the environmental aspect. It is massive because there are hundreds of thousands of compounds. We know we have over 150 active, but we're not measuring for all of them. And we do not know what the harm is in the long run. That's it. Thank you.
Well, thank you. Thank you so much, Elena. And we are a little bit over time, for which I do apologize. But I would like to ask one last question to all the panelists, also in thanking them for participating. And if I would ask if you can keep a very brief answer. My question to you, and I would start with Sergio, who opened, so we can do the reverse round, is after all you have heard today, after this discussion, what single commitment would you like to see the EU and the member states make in the next, let's say, 5 years on medication waste?
Thank you, Federica, for this. I would say a very short thing. I would say that I would look for a commitment in moving interoperability back in the agenda and moving it further and moving it for something that actually works, because this is something that can kickstart the implementation around the 27 or 28 countries that we're in. So I would put my money into the interoperability, I would say. Thank you.
Great, thank you. Lars, you're on mute, I believe.
Sorry.
There you go.
So probably, I think medication adherence should be a formal policy priority. But to do that, Europe has probably have to be enabled that other pharmacies can do other production stuff or logistics stuff for other pharmacies as well. So they have to look into it and make it probably possible. That's the Dutch way.
Thank you, Lars. Daniele.
Yeah, very quickly. I like practical stuff. So I talk about investment in my presentation and in my study. So investment has to be funded. So I would like that there could be some awareness and some fund dedicated to the transformation and digitalization of data and automation of repetitive activities. So that's the main core.
Thank you. Elena, over to you.
I agree with everything that was said. They're complementary things and fairly easy asks. I would add standardization to the interoperability and common indicators. And I would say that make reporting easier. Reporting adherence at the moment should be sitting at the primary care level. So I would end up with workforce. You cannot improve care without training and empowering carers, and also, of course, having a system. So back to healthcare professionals and workforce funding, not only implementation, but also funding reorganization of care, and so on and so forth. Thanks.
Thank you, Elena. And I would like to once again thank all of you for your time and your expertise and having shared this with us. I would like to thank Professor Guerra that has recorded his speech. I would also like to thank all our participants that have been with us today. I apologize if we went a little bit over time, but also would like to reiterate that the recording of this webinar will be available to you via our website. So will be the presentations, and I'm sure that you can reach out to us and we can put you in contact with the speakers in case you have any questions. I wish you a wonderful continuation of your day. Thank you so much for having been with us, and we'll see you at our next webinar.